single institution retrospective analysis of lymph node changes on breast MRI in patients who have high risk early stage breast cancer and are receiving neoadjuvant chemotherapy with or without immunotherapy on the I-SPY2 trial. Now, the I-SPY2 trial has shown that the addition of immunotherapy to standard neoadjuvant chemotherapy resulted in improved rates of estimated pathological response for hormone receptor as well positive as well as triple negative breast cancer. Now, to further try another drug and augment this effect, a combination of intratumoral SD101, which is a synthetic drug, along with pembro and chemotherapy was added, and also showed that there were increased estimated PCR rates when as compared to chemotherapy alone. But it was not. It was also associated with high rates of immune-related toxicity when immunotherapy was added to this. Now, this was a subset of a small retrospective analysis to see and assess the changes in the regional lymph nodes seen on MRI in these patients who were receiving neoadjuvant chemotherapy as well as immunotherapy, and explore and see if these changes in the regional lymph nodes ultimately correlated with the primary endpoint of complete pathological response and the residual cancer burden. So to check that, these patients were divided into 3 arms. One was the control arm, which received the normal chemotherapy regimen. The second arm, in addition, got 4 doses of pembro. And the third arm, along with pembro, also additionally received intratumoral SD101 drug for 6 doses. So this is a chart which shows that these patients were randomized for this investigational drug regimen. They were all followed by the adriamycin AC cycle that after they finished this regimen, and followed by surgery. Now, during this course, they also had multiple breast MRIs, which were performed in all the patients, and they were at baseline. The first MRI was done. The second MRI was done at 3 weeks. The third MRI was done at 12 weeks. And the last MRI was done at 20 weeks after finishing and completion of the treatment just before the surgery. Now, all these MRIs were read by a single breast radiologist who was blinded to the treatment arm. And they reviewed the MRIs and mentioned the longest diameter and cortical thickness of the largest ipsilateral axillary lymph node, also mentioned the number and the location of abnormal lymph nodes, and also the development of new abnormal lymph nodes over time. There were a total of 43 patients with median age of 45. Most of them were premenopausal. 58% were hormone positive, and 42% were triple negative breast cancers. Now, when the lymph node sizes were recorded across all timelines of MRI at baseline, 3 weeks, 12 weeks, and preoperative. This was the graph that was seen in the control group as well as the patients who received the immunotherapy. And what we see here is the change in the lymph node or the development of new lymph node over the time was significantly more common in patients who received immunotherapy as compared to the control group. But when these two groups of patients who did have increase in size and patients who did not have any increase in size of lymph nodes on MRI, when they were compared and correlated with the endpoint of PCR, that is complete pathological response or residual cancer burden, or even the hormone receptor status, that correlation did not have any statistical significant data. It was not statistically significant. This is an MRI of one of the patients who is on SD101 arm, and the MRI done at baseline, 3 weeks, and preoperative. Here we distinctly see that in the 3-week MRI, the size of the ipsilateral lymph nodes has increased. There is also appearance of newer lymph nodes over here. Now, when we look at the data of this SD101 arm 16 patient, we see that there are 10 patients who showed lymph node changes across all time points. And there were 7 patients who were receiving immunotherapy showed immune toxicity. But when you look at this chart, what you realize is that patient who showed some lymph node changes need not or did not necessarily show immune toxicity, whereas patient who did show immune toxicity did not necessarily show any lymphadenopathy changes or emerging of newer lymph nodes. So to conclude, what we can say that the addition of immunotherapy to the standard neoadjuvant chemotherapy in these patients did show who were associated with increase in the ipsilateral axillary lymph node on serial breast MRI. These were the patients who showed these changes, but they were not associated with worse pathological response at surgery. And therefore, these change in lymph node size or appearance of newer lymph node should not be assumed due to disease progression. This is a small retrospective study. The lymph node change of patients on immunotherapy was also not associated with either improved pathological outcome or hormone receptor status or immune-related toxicity. Now, whether these lymph node changes could reflect immunotherapy benefit needs to be investigated in a larger study and longer follow-up. And if we are able to do that, if we are able to show that these lymph node changes on the MRI were showing immunotherapy benefit by different means or by testing some biomarkers, then we will be heading and we'll be able to predict and we will be able to give more personalized treatment to these patients, where we can safely allow all these patients with good response as seen on MRI because of lymph nodes or other parameters to receive less treatment and have less toxicity, while we can also predict if patients who are non-responders can go ahead and have a complete neoadjuvant chemotherapy. So this is what we conclude from this study. Thank you very much.